In this short video, we're going to talk generally how to approach the 2B viva. The aim of the viva is to display adequate knowledge of a range of pathologies that would be appropriate to a senior radiology trainee. It's not always necessary to reach a diagnosis in every single case. What is more important is that you display a systematic, sensible, and very safe method of reporting. Overall, you need to demonstrate that you're a clinical radiologist, which means that you take into account the importance of the clinical information that they provide, and also that you have some understanding of the management pathway for each patient. In general, this is how I would divide up how to approach a case in the 2B viva. The first thing you want to do is briefly introduce the case. The second thing you want to do is go on to observation, so describe what you see. The third thing is to put together what you've described and what you can see and interpret these findings. So what kind of pathology is this? Use your surgical sieve. For instance, is this an acute pathology or is this a chronic pathology? Is this an infective pathology or is this a neoplastic pathology? Once you've interpreted the findings, you then need to make a diagnosis or give some differential diagnoses, because in certain situations you don't exactly know what the diagnosis is, but you should have an understanding of the potential differential diagnoses, and always start off with the most common and most likely one. After this, make sure you don't forget to talk about the management, and this is very important to demonstrate that you are a clinical radiologist. And saying vague things like I would refer to MDT is not really specific enough. You need to be as specific as possible and actually say what the MDT would do and in general what the treatment would be for the patient. So in terms of general tips for the 2B viva, I would say that most of the vivas start with a starter film. These are the straightforward, sort of easy films that you need to just be bold about and just quickly run through the observation, interpretation, diagnoses and management, and wrap it up nicely so that you can move on to the more meatier cases. The second thing I would say is that remember, safety is very important, and you need to there's few pathologies that you definitely need to recognize and manage, and I would count NAI and tension pneumothorax in this category. The third thing I would say is that it's very tempting to quickly ask for a second view once you've been given an initial x-ray, but the point of the viva is to earn every single case and every single second view that you get. So make sure you extract as much as you can from the first view that you're given. Lastly, I would say that it's very important to know how to deal with a situation in which you can't see the abnormality at first. The first thing I would say is don't panic, and secondly, just go back to your system and very importantly talk about your review areas and vocalize the pertinent negatives, because this will earn you marks. Hopefully, in most cases, the examiner will recognize that you're looking very hard and that you're looking in the right places, and they usually will give you some help at this point. So let's take a look at 3 example cases that we have. Let's take a look at the first case. So first, I'll scroll through the CT and you can have a look. And now I'll talk about the model answer for this particular case. So I would start off by introducing the case. These are axial slices of a non-contrast CT head. The next thing I want to do is observe. There is a density in the right MCA, and there is hypoattenuation in the right temporal lobe, and there is loss of the insular ribbon on the right side. Then I go on to interpretation. Putting these findings together, these appearances are in keeping with an acute right MCA territory infarct due to a right MCA thrombus. Importantly, there is no intracranial hemorrhage, and once I've written the report for the patient, I would add an alert so that the clinician knows that the patient could have thrombolysis if they are in the 4.5 hour window. Though overall this is a clinical decision, and they just need to make sure that there's no other contraindication to thrombolysis. In my institution, once a patient has been given thrombolysis, a routine CT head would be performed 24 hours afterwards to make sure that there's no hemorrhagic transformation. The same model answer is written here with the introduction and observation. And here we have the interpretation and management, which we've already mentioned. Let's take a look at case 2. So I'll give you 5 seconds or so to have a look at this X-ray before I tell you the model answer. So on this frontal portable semi-supine chest X-ray in an adult patient, you can see that there is lucency in the right hemithorax with lack of lung markings and a lung edge seen here. There is mediastinal shift to the left, and you can't actually see the right hemidiaphragm, probably because it's everted. In summary, these are features of a tension pneumothorax in the right lung, which is causing mediastinal shift to the left. This is a critical finding which needs to be alerted to the clinician urgently so that a cannula can be inserted in the second intercostal space in the midclavicular line, and you'd expect to hear a hiss after this has been done. And after this, a lung or chest drain should be inserted. The next slide shows what the model answer would look like written down. Here we have the interpretation and management in this particular case. The management is obviously very important because this is a life-threatening pathology, and any doctor or clinician should be able to recognise this and manage this. So let's take a look at the last case, case 3. So I'll give you 5 seconds to have a look at this case yourself. And now I'll talk about the model answer. So this is a frontal chest X-ray in an adult patient. There is a normal heart size and a normal mediastinal contour. The costophrenic angles are clear, and now I'm going to look at the lungs. Initially, I can't see anything obviously pathological in the lungs, but now I'm going to use my review areas. My review areas are the apices, which look fine, under the diaphragm, which looks fine, and behind the heart. And here behind the heart, I can see something abnormal, which is a soft tissue density lung mass. Given that this is a solitary lung mass in an adult patient, the most likely diagnosis is a lung malignancy, and I just want to make sure that there's no bony destruction, which would be due to a bony metastasis, and the bones look fine. In summary, this is a solitary lung mass, and the most likely differential is a lung malignancy. The patient would need to be referred to the lung MDT, lung cancer MDT, in which they would be worked up for a lung cancer, which would include a staging scan of the chest and abdomen, and in which they would be staged and their treatment would be determined by that staging. Again, here is the model answer written down. This is a case again where you need to demonstrate the management and also a sort of set piece in which you just need to practice it so it rolls off the tongue in the exam. I would say in summary, see as many cases as you can in your 2B prep. Practice the set pieces as we mentioned, things like left lower lobe collapse. And lastly, and very importantly, have confidence in yourself, because if you don't believe in yourself, no one else will. Good luck.